Hi, my name is Charles James. I'm President and CEO of North American Healthcare Management Services, and I'd like to welcome you to this session of the South Carolina Office of Rural Health Virtual Fall Conference 2021. I know we're all disappointed to be virtual, but better safe than sorry, right? We're here today to talk about value-based payments and what those mean for RHCs and FQHCs. What healthcare seminar or series or article have you seen lately that did not somehow raise the question or have an article about value-based payments? It is kind of a raging topic in healthcare, and it usually is at the headline of any publication that I've seen, some element of value-based payments. So let's talk about what they are, why we're talking about them, and of course, what they mean for us as RHCs and FQHCs. Value-based payment programs are, according to CMS, programs that reward providers with incentive payments, it's always about the money, for the quality of care they give to people with Medicare. They're part of a larger strategy to reform how healthcare is delivered and paid for in the United States. So this comes back to an article from 2019, and notice the terminology. Larger quality strategy to reform how healthcare is delivered and paid for. So that's no small order. The aim of the value-based programs, according to CMS and according to their MIPS programs, are, of course, better care for individuals, a focus on better health for populations of individuals, and of course that's a broad term, and lower cost. Pretty straightforward goals, but how we get there and how we define those things are, of course, always the important part. CMS quality payment programs focus on better outcomes for patients. How many providers feel that any quality payment program they've participated in has decreased their burden? That's one of the bad raps quality payment programs get, is they increase provider burden. It's kind of we can think of it, and a lot of us do think of it in terms of HIPAA, administrative simplification. It was not. But if the quality payment program in which your providers are participating are increasing the provider burden, then I would suggest perhaps it's not the right payment program to participate in. We'll talk about that. A more general term of what we're talking about, these value-based payment programs, actually more general than MIPS. MIPS is an alternative payment program, which supposedly align incentives across healthcare stakeholders. Who are the stakeholders? Payers, providers, patients. And advanced existing efforts, again, to reform the delivery system, ensuring a smooth transition to a new system. Look at that. So we're not talking small potatoes. The objective of this is to transform to a new system where we get off of the fee-for-service, pay-per-click merry-go-round. According to CMS and value-based philosophers, if there are any, that's the objective, to end pay-per-click healthcare. Align incentives, focus on outcomes. Decrease provider burden. What we really are hoping to achieve by that is to develop a team-based approach to healthcare that doesn't place all of the emphasis on just the provider, but that provider's team. Many of you have seen this chart. We have a spectrum of quality payment programs, starting with that on the left side of your screen. Fee-for-service with no quality incentives is where healthcare has been really through the 90s and early 2000s. Pure fee-for-service, some elementary payment for performance measures, but at the Medicare level, not a lot. Fee-for-service, that's what we think of as no quality, nothing on the quality spectrum. If we start to look at performance-based contracts, we start to see incentives for increasing access to primary care. Ever heard of that in a rural health clinic? And we look at specific metrics to achieve, and that's pretty firmly where MIPS is in a lot of ways. We heard a lot at the outset about bundled payments, and we haven't seen a big push for bundled payments. Certainly at the hospital and the institutional level, we've seen some of that and bundled payments, and we can see a lot of managed care contracts with bundled payments. You know what? Payers are effectively bundled payment programs. They're way down on the spectrum, but think of our payers get a lump of money to pay for their attributed patient lives from the payer's perspective, and that's how they pay you as providers. That's what these programs are passing on to providers. So when we start to proceed up the spectrum, what is the spectrum on which we're proceeding? Is we're going down the risk spectrum here, where in shared savings programs, we start to see where we have patient population accountability. We're coordinating some items with fee-for-service beneficiaries, and we quote unquote encourage investment. That means we're start to build systems that we're taking on more of the financial risk is the next spectrum. That's what it's all about. Transferring risk among all of the stakeholders in healthcare. And just like I mentioned with payers, payers have, let's say I have a Blue Cross Blue Shield contract. Here are the number of lives we have to care for, or I have a Medicare Advantage contract. Here are the number of lives we're going to pay for, and here's how we're going to pay providers. It's the same thing. The whole point is to transfer financial risk down from the payers, put that onto providers as well, all the way up to then, if you got a Pure as a provider, here's a lump sum for all of your patients, do with it what you will. That's what Pure capitation plus performance is, and then that's a full risk model. You're gonna pay for all of that care regardless of if it costs you more than the money you received. So for us in rural health clinics, we're down here still at the fee-for-service, performance-based contract, starting to move up into some of these shared savings programs. And that's some of what we're going to talk about. Medicare has two mechanisms, the one we know and the one we're starting to hear more about, which is our MIPS and our alternate payment mechanisms, alternate payment models. Some of these terms are interchangeable. A lot of this, remember the sustained growth rate? The sustained growth rate came about or was in effect prior to the passage of MACRA. And that's when fee-for-service, we had these rolling fee-for-service cuts we were facing, and Congress had to intervene every year and had a big giant price tag to fix it. Well, to fix it, we came up with MACRA, Medicare Access Chip Reauthorization of 2015. Let's not confuse that with anything in the Affordable Care Act. So different law, of course. MACRA created MIPS and APMs. So that's where the law came about, two different paths. And you all have seen these grids before relative to MACRA in the fee-for-service world, where MIPS, you've seen this chart relative to MIPS, where we have percentages for quality, cost, improvement activities, i.e. population management, promoting interoperability. Now, we've largely been insulated from this as rural health clinics, but start to get in to that frame of mind. And remember back when MIPS was first announced, we started to get letters for, hey, it's your performance year, performance data year. Submit 2014 data that will affect your 2016 MIPS score. And there was a disconnect between all of those fee-for-service provider numbers and our rural health clinic PTANs. so that Medicare doesn't largely know or didn't have a crosswalk for individual provider enrollment relative to our RHC P10. They're getting better at that, CCN, but that's where the disconnect was. So we'd get a negative adjustment on MIPS. We're supposed to submit performance data, but we didn't have any because we don't have any fee-for-service volume. So we were all confused. Well, that's where this came from. Now, along the way, as you see in this chart, MIPS has started to modify. MIPS has changed their weights on things, and of course, these measures come out and are updated every year. We look at who's eligible for quality payment programs and who's not, QPP. We have alternate payment mechanisms in addition to MIPS, so that we see, for example, some of our hospital providers or eligible clinicians under one mechanism, or under MIPS, we're an eligible provider. So we had all this matrix to determine whether or not we qualified. Now, here's the thing. I have an extra 2 in that date, I see. This came out on 8/6/2021. Here's the trick. All of the things that CMS has been doing with MIPS up until now has been, let's call it voluntary. Those have been called, CMS had flexibility in how they implemented the measures because it was the initial phase of the program. Now in 2022, all of a sudden, we're going to start looking at statutory requirements that start having to be fulfilled, and how these quality payments are more equitably distributed, and we'll see how that's going to roll out in future rulemaking notices. Now, I realize I'm still speaking Greek in terms of rural health clinics and FQHCs in a lot of ways, so bear with me. MIPS, we're still talking about MIPS. If you have enough volume of MIPS, now we have statutory requirements of how registration processes are going to happen, who's going to be involved, etc. MIPS proposals, their registration processes, we're way down deep in the weeds on things a lot of rural health clinics are not going to have to deal with this slide right here. We see that our MIPS and our MIPS proposals for 2022, here's something that I want to emphasize, is starting in 2022, that will be the, subsequent performance years, value pathways, alternate value pathways will become more and more available. And we're going to start having to do specific things with our subspecialty groups and how they'll be required to be subdivided into subgroups and report to MIPS as well. And these things are starting to come statutorily required. And again, the next 5 years are going to roll out pretty quickly in these. But my point is, we're going to start to see more stringent requirements for these groups on here and how they participate in MIPS. There are quality measures, and again, value pathways. I don't want to spend a great deal of time, but just get used to how these are divided. We have participants will select 4 quality measures. One must be outcome-based. We have to select improvement activities that have different weights depending on the activities, etc. The quality metrics would be in different categories like this. Chronic disease management, that of course would be a big focus for us as rural health clinics, or perhaps heart disease, stroke care and prevention. So I can see as primary care providers where some of these pathways would be those we might choose. 2022, we're proposing different provider types are eligible. It says everyone should be eligible, but who's missing? It's a trick question. Of course, we don't have rural health clinics and FQHCs on here. We have our providers, but we don't have us as facilities, which has been the whole part of the problem. There are low volume thresholds, which we as rural health clinics rarely meet. So as rural health clinic, as the low volume threshold for MIPS means that you have to have at least this much volume to participate in MIPS. Now, just to get back to basics, MIPS is the negative adjustment you've been taking on your fee-for-service claims. Some of you have few, some of you have more, depending on your hospital practice or not. But most of us are never going to meet $90,000 in Part B covered professional services as the low volume threshold. Now think about it. That is not $90,000 in our charges. That's $90,000 in Medicare covered charges. So that's the Medicare allowable. Most of our clinics, even those that may have some hospital practice, which most don't anymore, are not going to meet the $90,000 professional service threshold. We can bill more than 90 grand, have more than 200 Part B patients that we're going to bill fee for service, or provide more than 200 fee for service services that we're billing on a 1,500. And if we don't meet any of those, we can get into a virtual group or an opt-in, but to what point? Because there's no financial benefit, really. So this is the big Achilles heel for us as rural health clinics right here. Most of us do not meet this low volume threshold, so that all of the fancy diagrams and quality metrics and components on the slides I just showed you haven't applied to us so far. Most of us don't meet that low volume threshold. We don't have significant enough physician fee schedule payments, so it just hasn't mattered to us. Some of us at the hospital level are participating in ACOs, which are advanced payment mechanisms. Our hospital or our large institutional provider may be participating in an ACO, and we have to do things and report quality measures, but ultimately none of that value percolates down to the providers, typically. Many commercial payers are ahead of Medicare and starting to recognize, for example, if we have a certain percentage of our patients that we do wellness visits on, we get to particular threshold of all of our diabetic patients have received A1Cs. Some of our commercial payers are starting to pay on those measures. Medicare, we can't get in the game, even though we take the ding for the negative payment adjustment because there's no good crosswalk. These advanced APMs are additional payment programs. Once you're in an APM, you're automatically out of MIPS. So that negative adjustment you get maybe on your submitting on your lab claims, you get a negative adjustment on those. If you, in your large institutional provider, or a lot of our hospital-based clinics participate in ACO and they don't get the negative MIPS adjustment. This is why. As soon as your NPI numbers become associated with an advanced APM, you're excluded from MIPS adjustments. There's a 5% incentive available to advanced APM participants, but again, unless you're a pretty large provider, you're not going to be able to participate in a lot of those, certainly not as an individual provider. But again, that's how a lot of our hospital clinics get out of the MIPS adjustments, because their parent organizations belong to probably an ACO. All of these, we have an alphabet soup. An accountable care organization is an advanced alternate payment mechanism or model. All of these are required to use certified technology because it's all about mining for data. And our payments become based on our ability to satisfy quality measures. Unfortunately, check more boxes. But if we have good clinical integration on our whatever model we have, clinical integration should solve some of that provider burden. So again, back to, if you have a big provider burden, maybe you're not in the right payment model. You've heard a lot about Medicare shared savings programs. I've got a dog in this fight. An accountable care organization is a type of Medicare shared savings programs are in a type of a savings that accountable care organizations provide to their members. So again, just like that, it's an advanced APM, an advanced alternate payment model. So once a participant signs up with an ACO, again, CMS does have the crosswalk. Oh, we're taking this NPI out of the negative MIPS adjustment, and they're in an ACO. And the objective is Medicare shared savings. So the participants in the ACO agree to be held accountable for quality, cost, and the experience of care for their Medicare beneficiaries. This is where CMS is doing a large amount of promotion right now to get providers into accountable care organizations. Accountability for a patient population. Here are the patients attributed to us in our Medicare shared savings, accountable care organization. This number of Medicare patients, often the term people are using are lives, but we don't like to use that term. I like to use the term patients, people. We have accountability for our patient population. We have this many people we're taking care of, and we're measuring the outcome of this group of people. And we're coordinating the services that our group of people need. And yes, it does encourage us to be more efficient if we're so inclined. ACO members largely want to participate in an ACO and do these things. Those that don't join, and they're not in. But here's what you're doing. You're turning down free matching money for your 401k being your Medicare program, is what I equate this to. This is somewhat like matching funds in a 401k on your Medicare revenue. These are the mechanisms we're going to be using to participate in quality programs. Many of us are already doing these things. Many of us are fearful of participation because, oh my goodness, we're going to have to do some care management services. It's true. It's a highly encouraged component of this. Many of us are already doing annual wellness visits. Transitional care management services are a very important part of how we participate in quality programs. Preventive screenings, and it's all about reducing hospitalization, taking patients out of the hospital for their primary care. So let's give an illustration of how this works. We are here to reduce the cost of our patients to the Medicare program. We are here to reduce the cost in our practice, but many of us misinterpret the cost initiatives in accountable care organizations to practice costs. No, it's reducing the cost of our patients to the Medicare program. Your providers in your practice have risk scores. Your payers are monitoring you and your providers and your risk scores today, right now. You know who does not have that information right now? You. So Medicare and your payers know, the actuaries know. How do they know if you're reducing cost to the Medicare program? Here's an example. Transitional care management service saves the Medicare program $4,000 per transitional care management service. So your $200 visit saves Medicare $4,000. The actuaries know this. An ACO is typically set up to capture those cost savings and distribute them to members. So that if me, Joe Schmo, in my rural health clinic, and I participate in an ACO, I see a transitional care management patient. They leave the hospital, I call them, I have a face-to-face encounter. We've just saved Medicare $4,000 in future hospitalizations or length of hospitalization. Medicare aggregates all of this information based on your covered Medicare patients, and they pay your ACO the shared savings. Back down to the TCM service, let's say your ACO is 50-50. Medicare pays you $2,000, the ACO distributes the $2,000. The ACO is probably 60-40, so you get 60, the ACO keeps 40 for running the ACO. So that's in micro how it works. And now your performance year aggregates all of your transitional care management services and all the other services that you provide and aggregates risk scores and determines what those Medicare shared savings have been. And an ACO distributes those savings directly to the participants. That's how it's supposed to work. All of your Medicare Advantage plans, remember when I said in your commercial plans, and frankly, your MACs, they're all graded the same way. They get graded on their 5-star HEDIS and their STARS 5 components, HEDIS measures, CAP surveys. I always forget what HOS is. Pharmacy measures, health operations data. The Medicare Advantage plans are paid based on, here's a pool of money, pay the providers for seeing your patients. That's why Medicare Advantage plans sure can pay you your encounter rate as a rural health clinic if they want to. They've already been paid. They just may or may not want to pay you. Color me cynical. So that's how it works though. Get a lump of money to see the patients. Here's your performance. They're graded on performance, and then their pay, our commercial payers' pay, is based on their own performance. And they apply the same metrics to you. And that's why they're starting to align their own payments, offering commercial, our commercial payers are offering quality incentive payments to you as providers because of exactly they're being judged on the same performance. I'm oversimplifying, I know, but this is in general terms how the whole system works. So your commercial payers are already paying some kind of incentive in a lot of instances, 5% on meeting basic quality measures. Again, we see some, health outcome surveys, there's my answer on the HOS surveys. So common performance measures for our commercial payers. We're going to start seeing a lot more of these. Look down at PCMH, NCQA. A lot of times in the primary care setting, and what I'm hoping CMS will do is recognize PCMH either via NCQA or compliance team as an advanced APM. So then you get a bonus for being a PCMH, for example. It's all about data. Now, when I said we have a dog in the fight, North American has started a Medicare shared savings program for our rural health clinic clients, the Rural Advantage. And our whole purpose is to start to take advantage, that's a term I didn't want to use, is start to provide a vehicle for our rural health clinic and FQHCs, a better vehicle. Some participate in ACOs and never hear or see anything. There are some that participate in ACOs and have been happy. but many don't know what to do with their rural health clinics. It's all about, and your happiness with your ACO really is the extent to which you can share clinical data. And if you're having to go out as a provider and enter data into a portal to report to your ACO, is going to decrease your satisfaction and your compliance. We hear about physician and provider engagement. That's the engagement. How engaged are we to do the activities and get the information to you? It can only be done on an EHR. You can't do this via paper. So if you're a provider still on paper, you don't have to go electronic overnight, but part of your transition will certainly be to implement an electronic health record, yes. So it's all about health outcome and performance data that we can get out of our clinical records electronically. Here's a good demonstration. Now I know we're in South Carolina. I don't know the South Carolina model off the top of my head, but I know Illinois. This was just before the pandemic hit. We were supposed to start getting, we all have to use a different phrase for it. Integrated health home, think patient-centered medical home. It's the same thing. And we would get a per member per month payment. Look at these payments, not too bad. If we participate in, if we're a patient-centered medical home, integrated health home in Missouri, we have to, or in Illinois, excuse me, jump through certain hoops. And then not only do you get your health clinic encounter for every time you see the patient, but for your whole patient panel, you get this amount of money per month, per patient per month. Is the phrase. Are you seeing this correctly? Yes. Now these payments haven't started. So like I said, this was getting rolled out just before the pandemic, and then, you know, we're still in the pandemic. So, but Missouri, of all things, actually had a pretty robust model going for some time. So remember, we've talked about Medicare, and we don't qualify for MIPS. We can participate in ACOs, it's a Medicare level, right? Some commercials are paying us incentives. And now this is a way to start looking at your Medicaid dollars and how you can participate in quality programs at the Medicaid level are largely through these primary care health homes or patient-centered homes, etc. Oh, I did not get in Missouri, there's a really nice $66 per Missouri Medicaid patient per month for an integrated health home on top of your claims revenue. Back on the ACO payments, for example, the ACO we've started, this is all money in addition to claim revenue. So here's the trick with value-based payments. They're here. They're coming. They're statutorily going to be, CMS has a statutory responsibility to start implementing these measures more broadly. Get used to the terminology. Look for ways to participate. Certainly if you're already doing some of these things, but here's my suggestion, why I say it's not a huge hill to climb. If you're not doing care management services, do 2 patients. You don't have to do 100. Start small. Walk before you run. If you're not doing, most of us are doing annual wellness visits. Look at the percentage. How many of your patients are getting their annual wellness visits? Right now it's a pandemic. Everybody's busy, I know. At some point, this too shall pass. It may not be 2023 until we're talking about an endemic or COVID 2021, but whatever. Again, that's the cynic in me coming out. We will start talking, these programs are now statutorily going to become more prominent. And we have initiated a mechanism for our clients to start. If you are not participating in ACO, I highly recommend you look at them. You look at one. Do they speak rural health? Probably not a lot of them. Many do. So join something. Don't turn down the 401k matching money from the federal government. It's not 401k, I get it. But don't turn down your matching money. Find a way to get it. What this does is, from a provider perspective, think about being able to get more money for what you're already doing and help step off of the revenue merry-go-round of I only have one way to increase revenue, and that's to see more patients. So the whole point of this is to start paying you for outcomes and quality. We'll have bumps, right? But this is where the world is going, it seems. I suggest educating yourself and looking for ways to participate as a rural health clinic or FQHC. Oh man, I got my slides all mixed up. That was the problem. So here's our benefit in Missouri. You can see up through 2019, $65. So if we determined for one of our nurse practitioners, if she had 100 PCH patients, it was 80 grand to her. In addition to claim revenue. A little outpost nurse practitioner practice. Where else are you going to pick up 80 grand in revenue? Not very many places. It's here, it's coming. I really hope that you all find ways to participate because I think it's an exciting opportunity. There's a lot of misinformation out there, but get your own information. There are ways to participate in these and add, that's what we're talking about, adding value to your practice. That's what we're talking about, very directly. I'd love to talk more at length about any of these mechanisms. As you can imagine, I can go on longer than anybody wants to. So, value-based payments. In the words of Fast Times at Ridgemont High, learn it, know it, live it. And I'll let you go back for that movie reference. So, thank you everybody. Glad to see you virtually. Hope to talk to you soon.